history of discharge from the swelling.
Dr. Akash, please continue.
No history of pain, ear pain, hearing loss. No history of change in voice, foreign body sensation in the throat. And there was no history of difficulty in swallowing or pain in swallowing.
This next slide. Sir, we
Just a minute.
Some problem?
Just a minute.
yes, now we can see your slides.
There was no history of breathing difficulty or noisy breathing. No history of fever, evening rise of temperature, cough or hemoptysis. No history of weight loss. No history of similar complaints anywhere else in the body. No history of dental complaints. Past history. No history of diabetes, mellitus, hypertension, asthma or tuberculosis. Treatment history. Patient had taken oral medications on several occasions from a local physician, but symptoms did not subside. Patient has been consulting in PPS GMC from last 1 week. No other surgical or medical history. Personal history. Diet, vegetarian diet, appetite decreased, but intake normal. Sleep adequate. History of BD smoking present since past 35 years and currently smoking 70 pack years. No history of any other addictions. Bowel bladder habits normal. General physical examination. Patient is conscious, cooperative and well-oriented to time, place and person. Patient is poorly built and nourished. Pulse rate is 82 per minute taken in the right radial artery. Normal in rhythm, volume. Blood pressure 140 by 90 millimeters of mercury taken in supine position in the right brachial artery. Respiratory rate 20 per minute. Right cervical lymphadenopathy present, which I will be discussing further. No signs of pallor, icterus, clubbing, cyanosis, edema, or lymphadenopathy elsewhere present. Local examination of the neck. On inspection, a solitary globular swelling of approximately size 5 by 4 centimeter on right side of neck extending approximately half centimeter below the body of mandible, 2 centimeter above and 4 centimeter lateral to the thyroid eminence and 2 centimeter medial to anterior border of sternocleidomastoid. Skin over the swelling appears normal. The surface appears smooth with regular margins. Swelling does not become prominent on contracting the sternocleidomastoid muscle. There are no visible pulsations and no other swelling in the neck, no visible scars or sinuses, and swelling does not increase on cough reflex. On palpation, a single globular swelling of size by 5 by 6 centimeter felt in right level 2 of neck, which was extending half centimeter below the body of mandible, 2 centimeter and 4 centimeter lateral to the thyroid prominence, and 2 centimeter medial to anterior border of sternocleidomastoid, 4 centimeter deep to the sternocleidomastoid laterally. It was non-tender and no local rise of temperature. The surface was smooth, well-defined margin, and stony hard in consistency. Skin over the swelling is non-pinchable. The swelling is non-mobile in both side-to-side and craniocaudal direction. No fluctuation, non-compressible or reducible, and no pulsations felt over the swelling. There was no other palpable swelling present in the body. The trachea is midline. Laryngeal crepitus was present. There was no bruit on auscultation of the swelling. Oral cavity examination. Mouth opening adequate. Lips, angle of mouth, teeth, gingiva, buccal sulcus, gingivo-labial sulcus, buccal mucosa, hard palate, anterior two-thirds of the tongue. Retromolar trigone was normal. Bimanual palpation was normal. Opening of the parotid duct and submandibular gland duct was normal. Oropharyngeal examination. Bilateral anterior pillars, tonsils, posterior pillars, posterior one-third of the tongue, base of tongue palpation, soft palate, posterior pharyngeal wall, tonsillolingual sulcus normal. Tongue movements were normal. On indirect laryngoscopy, base of tongue, vallecula, epiglottis, aryepiglottic fold, arytenoids, false chords, piriform fossa, true chords were normal. Nasal cavity examination, anterior rhinoscopy normal, posterior rhinoscopy normal. Ear examination was normal. Scalp examination was normal. On systemic examination, GI system, no hepatosplenomegaly. Abdomen was soft and non-tender. Respiratory system, air entry was equal on both sides with no adventitious sounds. Cranial nerve examination was normal. And cardiovascular system, S1, S2 was normal with no murmurs. On finishing the examination, the history and the examination, came to a differential diagnosis of metastatic lymph node and lymphoma. And my provisional diagnosis is left metastatic lymph node with an unknown primary CT0N3B M0. I'm done, sir.
Okay.
Dr.
Doc-
Vipin? Ah,
Yes.
Doc-
Yes.
Dr. Akash, go back to your slide of provisional diagnosis. Just one slide prior to it. Just one slide prior to it. Metastatic lymph node or lymphoma.
Yes, sir.
Do you call it as on clinical examination? Do you call it as lymphoma, or there is some better word? You can call it as, I think, lymphoproliferative disorder. Lymphoma is a diagnosis by histopathology, and general, I think, broad diagnosis should be,
Yes, sir.
anyway. Any other?
We can we can simply label as cervical lymphadenopathy.
Yeah, that is also true. But since we are talking of the postgraduate, so I think differential diagnosis, he should be more this. Metastatic lymph node is okay, fine with me. Broad diagnosis, as Dr. Ranga said, it should be cervical lymphadenopathy. So that is what I feel. What about
Prakash?
Dr. Head
Yes,
and
sir.
neck
Good
surgeon,
evening,
sir?
sir.
Hey,
Apna Vipin
Yes, sir.
will make more this thing.
yeah. Thank you. So Akash, why do you kept the metastatic lymph node as your first diagnosis? Can you tell me what is in favor of metastatic lymph node?
Sir, on examination, the swelling is a globular swelling, and secondly, sir, the movements on palpation, there was no movement in the lateral direction or the anterior in the craniocaudal direction. And
What does it signify?
sir,
If it is fixed to the underlying structure, what does it signify?
Sir, if it is fixed to the underlying structures, that means there is extracapsular invasion or extracapsular spread of the lymph node to the surrounding structures, either to the muscle or to the skin or to the fascia.
Okay.
what
And,
was the consistency of the lymph node?
Ma'am, the lymph node was stony hard in consistency.
Did you mention that in your findings?
Yeah, he mentioned, ma'am. He mentioned.
Yes, ma'am.
Okay, okay. So it was
It's
hard,
stony
and you said
hard,
it is
Yeah.
and
fixed to-
fixed.
Yes, ma'am. It was fixed to the underlying structure on palpation, and also the skin was not pinchable.
You have palpated is single swelling or there were multiple swellings?
Ma'am, it appeared to be a single swelling, a globular single swelling
On inspection
on
or
inspection and
palpation
palpation.
also? Achha,
Yes, ma'am.
okay, okay. Can you go back to your examination? Palpation. Okay, okay, right.
So Akash, I think in exam you should summarize it that this is a middle-aged man who is having history of smoking. He is a heavy smoker, and he presented a swelling which is 6 months 6 months back, and which is in the level 2, which is fixed to the surrounding structures, and it is fixed to the skin. So it is most likely
Yes.
to be a metastatic lymph node.
Yes, sir.
Okay.
You also kept a diagnosis of lymphoma, which Dr. Aditya said that you should be putting as diagnosis of lymphoproliferative disorders. But that means lymphoma only, na?
Yes, ma'am.
So what else? Anything else you can put it here? I mean, differential diagnosis.
Ma'am, another differential could be a leukemia.
But on clinical
Ma'am,
examination, you are labeling as a lymphoma. Then what is the finding of a lymph node in lymphoma? On examination, on digital examination, you can say.
On clinical
sir,
examination, he meant to, yeah.
on clinical examination or digital examination, in lymphoma, the swelling will, the lymph nodes will be rubbery in consistency and there will be matted. And sir, also there will be other B signs like fever, weight loss, loss of appetite. All these
What are the
symptoms,
B
if there are
signs?
present.
Be specific about the B signs.
Ma'am, fever can be there, significant weight loss, then loss of appetite, and
What else?
What do you mean by significant weight loss?
so 10% weight loss in 6 months.
10%. Okay. But you are labeling this is a lymphoma, and you are in clinical examination, you are saying the globular lymph node that is attached to the skin also hard in consistency. Then how we can label it is a lymphoma and differential?
Sir, I would like to further investigate the patient. I would like to do some the special investigations like fine needle aspiration cytology and
That
No,
is
but
the part of investigation. Just patient come to your clinics and you examine and you say these are two differential, but one differential is right. You are saying it is a metastatic lymph node, but in
since there are no B signs, do you still want to keep a differential diagnosis of lymphoma?
yeah,
Neither on history
that is
nor
my
on clinical
query.
examination.
Clinically, patient say I have only the lymph node, no weight loss, no fever, no night sweat, nothing. Then how we can put this thing in lymphoma group?
uh,
Akash, one more
there
thing.
was
What is the commonest cause of cervical lymphadenopathy in India?
sir, in India the most common cause of cervical lymphadenopathy is tuberculosis, presenting as a multiple multiple
What is the commonest
lymph node
cause, you
swelling
said?
with matting.
Hello,
Sir, tuberculous lymphadenitis.
can you hear me?
Yes, sir.
Hello,
We are hearing Dr. Bhargav.
hello.
We can hear you, sir.
Hello,
think-
Aditya sir. You're audible, sir.
Hello, can you hear me now?
Yes, yes, sir.
Yes, yes,
No,
You're
yes.
audible.
I'll log in again. Thank you.
So
So
Aditya,
your
sorry,
yes, yes,
Akash,
please.
then
Yes,
what is the
go ahead.
clinical diagnosis? You said it is T, it is. Can you go to the lymph node staging? It's T.
So T0, N3B, and M0.
N3B. Why it is N3B?
Sir, because there is extranodal extension, it is fixed to the skin and also to the surrounding structures. That is why, sir, it is clinically N3B as per the AJCC guidelines 2017.
Okay.
Sir, this T0 and 3B, we can put on only in the provisional or it is a radiological diagnosis?
No, sir, radiologically, we will have to assess. Clinically, definitely, if it is present, radiologically, more chances are there that it will be N3B.
can label it clinically, sir. You can label it as clinically as a metastatic lymph node.
He's
And,
written it CT0, so it's clinical staging.
Yeah, it is CT0.
Clinical TNF. Yeah, clinical TNF. So you have written M0, and it is a clinical diagnosis, you said, no? Clinical staging.
Yes, ma'am.
So can you say M0 on just on clinical?
Ma'am, on my clinical examination of abdominal system, respiratory system, I could not find any significant signs or symptoms that could suggest that there is some metastasis. Because on respiratory system there was no adventitious sound, no history of cough, no history of hemoptysis, no history of jaundice, no history of no history of any other significant weight loss, no history of any body pain or a fever. So on that basis, on the clinical basis, we can say that it is M0. But to confirm the diagnosis, we will have to go
Or
for
we'll write
radiological
MX.
investigation.
Dr. Vipin, what do you say? We should write MX
It's-
or M0?
It's okay to write M0 also, ma'am, because he has able to justify that on history
Yeah.
and examination, there is no evidence of any metastasis.
To
in this
suggest,
patient.
okay, right.
So it is okay,
Then-
ma'am, to write. Yes.
Okay.
So how would you like to proceed from this place?
Sir, I would like to go for an ultrasound guided FNAC of the lymph node, and along with that ultrasound, to check for any other nodes present in the neck, and at the same time go for diagnostic, the fine needle aspiration cytology, and on that, if it is if it comes out to be a carcinoma, then after that I would like to go for the findings for or to look for the either the HPV, that is human papilloma virus, or Epstein-Barr virus, because recently it has been seen that in oropharyngeal carcinomas and nasopharyngeal carcinomas, the role of uh, human papilloma virus and Epstein-Barr virus respectively is very common. So I would like to go for first FNAC, and after that also would like to go for viral, to check for any viral content is there or not.
Since you
Virus
are,
will not be
we are
there as such. You will ask for a P16, basically, which is a surrogate marker for HPV, and for that you require a core needle biopsy. And for EBV also, you will require a core needle biopsy, which gives you much better material than on FNAC. So how do you, why do you need to do an ultrasonography and FNAC?
Sir, ultrasonography to look for any other, because sir, first of all, it is a very basic investigation. It is readily available, and the diagnosis of a lymph node or a metastatic lymph node can be made on the initial, when we want to make a proper diagnosis in that way, and then go for further investigation. So ultrasound is the best modality at this time in our clinical setting. And on ultrasound, if we get a metastatic node, then we can further go for other radiological investigations. And ultrasound guided FNAC gives a better diagnostic value than only doing a FNAC without a USG.
Ultrasonography basically is to evaluate rest of the neck also. This is a big node, so you can use ultrasonography for evaluation of any other lymph node in the neck. So that is good enough. Suppose you do an FNA and it comes out to be a moderately metastatic squamous cell carcinoma in the same patient. So how do we proceed after that?
Sir, once we get this diagnosis as a moderately differentiated squamous cell carcinoma, go for a core needle biopsy to look for P16 and in situ hybridization for HPV and EBV. And along with that, if we need to see the primary first, where the primary is coming from. So for that, we can do on anterior rhinoscopy and posterior rhinoscopy. There was no significant finding. So we can do a rigid nasal endoscopy on OPD basis at the same time to look for areas in the nasal cavity if there is any growth or if there is any suspicious lesion, and also into the nasopharynx, and into specifically in the area of fossa of Rosenmuller. And if even that is negative, then we can go for a rigid 70-degree rigid laryngoscopy and look for areas or any significant area where there could be a growth, possibility being the base of tongue or the vallicula or the piriform fossa. And if still that is negative, or if there is no significant lesion or any lesion there, then we can go for a higher imaging modality, that is computed tomography, contrast enhanced, or an MRI.
Dr. Akash, what areas would you like to concentrate while looking for primary, which can drain to this area and is having squamous cell carcinoma? What are the areas? Just specify some 4-5 areas. Yeah, we'll do full head and neck oriented examination, but what are the areas which you want to concentrate? Listen.
Ma'am, the first area is the nasopharynx, areas of the nasopharynx, then the base of tongue, then the tonsillolingual sulcus, then the epiglottis. Ma'am, these that is the vallicula. These areas drain to the level 2 lymph node and also level 3 and level 4, but specifically to the level 2. And yes, ma'am. And ma'am,
About
clinically
piriform fossa and hypopharynx.
yes, ma'am. Piriform fossa and the hypopharynx.
Okay.
Most vascular structure for the occult primary is the piriform fossa.
Yes, sir.
Akash, this was about the metastatic squamous cell carcinoma. So which other pathologies can you see in this region?
Sir, there can be adenocarcinoma, also undifferentiated carcinoma, and also there can be a carotid body tumor or carotid aneurysm presenting in this region.
Does it present like a hard swelling fixed to?
Yeah.
Does it present like a hard swelling fixed to skin and underlying structure?
Sir,
You
other
said you are dealing with a
presentation
lymph node, na? A lymph node mass.
No.
So carotid
No.
body tumor at this stage, why do you want to?
No, actually, sir said in this region. That is why I
Okay.
said about it.
You said Akash, you said undifferentiated carcinoma. Is it
Yes,
a
sir.
different modality than a squamous cell carcinoma? Is it a different modality, undifferentiated carcinoma?
Sir, here we cannot know which kind of carcinoma, which
No,
kind of
there
cells
is
are
no
present.
diagnosis as undifferentiated carcinoma. It is a subset of squamous cell carcinoma only.
Yes, sir. Yes.
Adenocarcinoma
sir.
is squamous is the most common. Squamous carcinoma, around 70% of the unknown primaries will
Yes.
be in the squamous region. Other can be adenocarcinoma. Then you can have neuroendocrine tumors, usually from the supraglottis, which can present as a secondary in this level. Then fourth entity is the tumors which arise from outside the head and neck. Can you tell me which tumors outside the head and neck region can present as a metastatic lymph node in the neck?
Sir, it can present in most commonly in the level 3, level 4. Sir, carcinoma of the liver, esophagus, gallbladder, prostate, and lungs. Sir, these carcinomas can present in the neck, either in the level 3 or level 4 or level 5 lymph node. Level 5 most commonly the level 5B, that is supraclavicular or virtuous node.
That is a left supraclavicular. Virtuous node is left supraclavicular node. So in decreasing order of frequency, these tumors are tumor of the breast, lung, kidney, and testes. So in the
Yes, sir.
decreasing order, these are tumor which metastasize to the neck.
FNAC can also show lymphoma-like structures. No, lymphoma-like structures, like findings. No, Akash?
Sir, ma'am, it can show Reed-Sternberg cell, RS cell. Those are popcorn-like cells. So a diagnosis of lymphoreticular a lymphoreticular disease can be made on that basis. But to confirm the diagnosis, we will need a core biopsy or a biopsy or a excisional biopsy of the lymph node.
Akash, is there any role of immunohistochemistry in the diagnosis of metastatic lymph node?
Sir, the immunohistochemistry can only prognosticate the diagnosis, or we can say that it can be the most likely diagnosis. Sir, we have cytokeratin or cytokeratin for squamous cell carcinomas, for which we can ask the pathologist to look for.
If
So
the FNAC is done right, and FNAC show the B lymphocytes with irregular nuclei and scanty of the cytoplasm, and you make the diagnosis B cell lymphoma. Then if you send the patient for the tissue for the immunohistochemistry, then which CD marker you to expected to become on the report?
sir, CD 15 and 30, sir. Not, sir, I'm not sure though.
Okay, that is CD20. Dr. Uma, please.
Yes.
So, Dr. Aditya and Dr. Vipin, please.
Okay. So you have a metastatic lymph node. So can you define what is a true carcinoma of unknown primary?
Sir, carcinoma of unknown primary is a presence of a metastatic lymph node, most commonly squamous cell carcinoma, and the primary has not developed till 5 years. Only then we can say that it is a true carcinoma of unknown primary origin.
So the definition is, as you rightly said, that you have a metastatic lymph node, and the index primary tumor does not appear or is not diagnosable in the next 5 years. So this is a true carcinoma of unknown primary or true occult. Secondly, what is the carcinoma of unknown primary? This is a true one, but what is usually we are dealing with? This is what sort of what would you label it as?
Sir, in
Simple hai. This diagnosis can only be made in the prospective. So we can make this diagnosis 5 years from now, if it is a true
Yes, sir.
carcinoma of unknown primary. But as of
Sir,
today,
here
we cannot label it as a
carcinoma.
true. It is still under evaluation.
Yes, sir. Yes, sir.
So carcinoma of unknown primary है, ना कि ये true carcinoma of unknown primary, ये true occult primary है. So
Yes,
how
sir.
do you go about it? This is a carcinoma of unknown primary. We have a metastatic lymph node, which is most probably squamous cell carcinoma with extranodal extension. So how do we go about it? So you got the difference between this terminology?
Yes, sir. Yes, sir.
आज से 5 साल बाद ही तो हम बता सकते हैं कि अगर इसको पेशेंट को ट्रीटमेंट के बाद प्राइमरी नहीं आई है तो ओनली देन वी कैन टेल आफ्टर 5 years, ना? Currently the working diagnosis carcinoma of unknown primary.
Yes, sir. It will be sir, after 5 years. It will be a diagnosis of exclusion. Even after doing exhaustive workup of the patient,
Okay.
and serial radiological investigation, that is PET CT, and
So
even
you
after
tell me
that,
what is the order of investigation?
sir, sir, as per the algorithm, sir, we have to go for first for the FN ultrasound guided FNAC. Along with that, core needle biopsy. After that, we can go for PET CT of the neck uh, to uh, to find the primary, more specifically into the in the areas of nasopharynx, in the area of base of tongue, in the area of piriform fossa, and uh, sir, if still we are not able to find the primary, we will have
And
to go for
tonsils, palatine tonsil.
palatine tonsils. Yes, sir, palatine tonsils and the base of tongue. And still we are not able to find the primary, then we will have to go for pan endoscopy. Sir, in pan endoscopy, we will do a flexible nasopharyngoscopy, uh, esophagoscopy, and bronchoscopy. And this procedure will be done under general anesthesia, and it is preferable to do after doing PET CT of the patient.
Okay. Any role of other diagnostic modalities like narrowband imaging in detecting the primary tumor?
Yes, sir. Sir, it is an upcoming investigation where in narrowband imaging we can see increased blood vessels in the area, in the suspicious area, and we can take a biopsy from that area. And sir, also
No, this is not the correct way to describe narrowband imaging. Can you tell me what is
Is it
narrowband imaging? What is
is
the
it
basic
increased
principle?
blood vessels or something else?
This is not increased blood vessel.
These are not increased blood vessels, as Dr. Vipin is saying. What is it, Akash?
I'm not sure actually.
Basically, this is a new
Sir,
neoangiogenesis that occurs in the submucosal region, and this angiogenesis has got various patterns, so which are
Patterns.
suggestive of some uh, benign and malignant pathologies. It is classified into 1 to 5 categories, and different categories, particularly the perpendicular type, in which the new angiogenesis occurs in a particular direction. I think you have to go and see the pattern. So on the basis of that, it will guide us as to from which part we need to take the biopsy. So which is the most representative part, and where all this new angiogenesis occur, and we can take biopsy from representative area. So that is the whole purpose of doing NBI. NBI certainly increases your sensitivity of picking up a primary tumor, particularly in the carcinoma of unknown primary cases.
yes, sir.
So what to do?
Sir,
There is
and
no
along with
lymph
that,
node. Yeah, please, ma'am.
Yes, Akash?
sir, along with that, we can go for tongue-based mucosectomy and bilateral tonsillectomy and biopsy from the nasopharynx, biopsy from the piriform fossa, and ipsilateral piriform fossa and bilateral tonsillectomy, and biopsy from the nasopharynx. And sir, this can be done under general anesthesia at the same time, and the chances of getting a diagnosis of primary carcinoma increases around 50% with this modality, sir.
So you take blind biopsies from these areas, but not from tonsil. For tonsil, you have to do tonsillectomy. You mean to say that, okay?
Yes, ma'am. And specifically bilateral tonsillectomy, ma'am.
Lateral tonsil. Why you want to do a bilateral tonsillectomy if it is a...
Sir, in unilateral tonsillectomies, it was seen that 75% chances were there that it will be ipsilateral, but some studies suggested that in bilateral tonsillectomy or the contralateral tonsils, 10% chances were there that there could be a primary in the contralateral tonsil, sir.
It is 90 to 1, not 70 to 1. 90% chances are that it is on the same side, and 10% it can be the primary can be on the opposite side. Right? So how do you evaluate your case when you have a bilateral metastasis lymph node, bilateral nodes?
Sir, here, so the metastasis, specifically more commonly the tongue, when the primary is in the tongue, so they tend to be bilateral, and sir, in this case, in case of bilateral neck nodes, sir, we
So
will
the-
have to follow the same.
if
Sir,
it is this case has unilateral lymphadenopathy. Suppose this case had bilateral lymphadenopathy, would your biopsy pattern would change, or it would be the same?
Sir, we will have to take biopsies from from the both sides. Sir, because we don't know where exactly is the primary, or whether it is lying in the midline, specifically in the base of tongue.
Yeah, so Akash, your logic is right. When there is a bilateral lymphadenopathy, you have to look for structures which can throw metastasis on both the sides. Which are those structures? That is the nasopharynx. Secondly is the lingual tonsils.
Yes, sir.
So in this case, you need not to do a palatine tonsillectomy. In unilateral, you need to take biopsy from both the tonsils. But when there is bilateral lymphadenopathy, it is not feasible that primary from one tonsil and from other tonsil is presenting as secondary simultaneously. So this goes out of the logic. So when there is a bilateral lymphadenopathy, you are suspecting a midline structure, and those midline structures are the nasopharynx, lingual tonsil, and base of the tongue. So in that case, you will not do a tonsillectomy. Palatine tonsillectomy is not required. You should be focusing on lingual tonsils and base of the tongue and nasopharynx. You got the logic behind it?
Yes, sir.
Okay, that's so nice. So you have done an exhaustive workup, and still there is no evidence of any primary tumor. So what do you do?
Sir, we will have to go for sir, since the disease is N3B, sir, we will have to go for a radical neck dissection, and first of all, we will have to go for the radiological investigation, and we will have to see the encroachment of the structures, whether it is encasing the common carotid artery, or and how much whether we will need to remove the common carotid or not. We will have to
What radiological
assess it
investigation?
radiologically.
Specify. Can you specify?
Ma'am, if it is encasing more than 270 degree
No,
of
what
the common carotid
radiological
artery,
investigation do you want to do? What radiological
ma'am,
investigation?
ma'am, contrast enhanced MRI. Ma'am, contrast enhanced MRI to see the structures that are encasing, or which have been encroached by the metastatic node, and plan the surgery accordingly.
So CT or MRI? CT or MRI? MRI.
Ma'am, CE-MRI will be a better modality for soft tissue lesion.
Next.
And ma'am, we'll have to go for a radical neck dissection, and in radical neck dissection, after doing it, and after 6 weeks, after 3 weeks, we'll have to go for concurrent chemoradiotherapy.
So you want to remove level 1 to level 5 lymph nodes along with sternocleidomastoid accessory and IJV. Plus you want to, but Okay, and then you want to give chemoradiotherapy after
Sir,
how much
after
time
3
you want?
weeks.
After?
So minimum 3 weeks, sir. Minimum 3 weeks, sir.
No, healing will not be appropriate in 3 weeks. The recommendations are you should wait for a period maximum up to 6 weeks, but usually 4 to 6 weeks. It is 3 weeks is too less for healing. And particularly in a case like this, when you're removing the soft tissue cover, sternocleidomastoid muscle, and you are compromising the vascularity of the carotid artery. So, and how would you evaluate further? Suppose how do you decide about the chemotherapy? What are the indications of giving chemotherapy after the neck dissection?
Sir, if the disease is N2 or N3, sir, we should consider giving chemotherapy. And
There are only two. There are only
concurrent
two.
chemoradiotherapy.
No, radiotherapy is appropriate. There's no doubt about that. Radiotherapy has to be given. There are only two indications of adding chemotherapy in head and neck. That is, first is a positive surgical margin. Second is when there is an extra nodal extension. This patient has extra nodal extension. So that is why you need to add chemotherapy to this patient. So which sort of chemotherapy you want to give?
Sir, cisplatin.
Okay. So single
Uh,
modality, single drug regime using cisplatin is good enough. That will take care of. And how much radiation you want to give to the neck?
Sir, 6,000 to 6,500 grays.
Okay, so 60 to 66 gray is appropriate, but okay, that is for the secondary neck. So what about the primary tumor? The primary tumor is still somewhere over there. Huh? You want to look for that primary tumor?
Sir, sir, it is said that when we give the radiation to the neck, uh, uh, if there is a primary present which is still hidden with the chemotherapy, there is a possibility that even that gets treated. So, however, we have to keep a surveillance on the patient by doing uh, FDG PET CT, and up till 4 years, and so that we can look for a primary which at the time of surgery or at the time of treatment it was occult, but whether if it has whether it has become uh, positive, or whether we can see on the radiological imaging.
So
How
primary,
frequently do you do? How frequently do you do these investigations in surveillance after giving treatment? You've done radiation or chemotherapy, whatever. Then you said that you want to put the patient on surveillance for 5 years. So how frequently do you call the patients for doing these investigations? You want to do PET CT or want to do clinical examination, whatever?
Ma'am, I'm not sure about the guidelines for that.
So, okay.
so I'll just answer that question. The first recommendation is, these are NCCN recommendation, that the first visit in the first year you can visit the schedule every monthly schedule. And the first imaging can be done minimum after a 3 months period. There should be a gap between the completion of radiation and chemotherapy and getting a first investigation done. That should be at least 3 months, because the effect of radiation and chemotherapy, it continues even after it is stopped. So you should wait for at least 12 weeks. In the second month, you can follow up these patients every 3 months, and then with increasing duration between the intervals. And the recurrence has to develop, most of the recurrences will develop in the first 2 years. And out of that, 90% of recurrences will occur in the first 1 year only. So this is how you need to follow these patients intensively during the first 2 years after the treatment. And secondly, I think the question still remains unanswered, that what will you do the primary? Do you want to radiate the primary possible sites of primary or suspected site of primary like
Yes.
nasopharynx, hypopharynx.
Yes, sir.
But the answer to this question, you said that when you give radiation to the neck, they get automatically
Yes, sir.
radiated. This is not the case. In today's area of highly conformal radiotherapy, you design the fields. In IMRT, you actually design the field so that effect of radiation doesn't go outside. So there are two schools of thoughts that you radiate the ipsilateral structures when you're giving radiotherapy. So you can give, if you're giving 66 over here, then you can give around 50 grays to the primary suspected site like nasopharynx, base of the tongue,
Yes, of tongue.
palatine tonsils. These are the areas where you can target, and then you can give 50 grays in 25 fractions to these patients. But the real doubt comes whether to do the radiation on ipsilateral side, or you can give pan mucosal radiation. That covers the entire head and neck region, the suspected site in the entire head and neck region. So that is a question. So there has been several studies in which I'll just tell you what is the outcome of these. There has been studies in which they say the pan mucosal radiation, that is radiating all the suspected side on both the sides, will give you slightly better loco-regional control, but there is no better overall survival in this patient. And remember, all the survivals in any cancer, you have to increase overall survival. Overall survival is the only thing that you compare between the modalities. That A is better or B is better, you must prove that there is difference in the overall survival, which is statistically significant. So in this case, there is no difference in the overall survival, whether you give radiation to one side or to give radiation to both the sides. But there is definitely slightly higher, and loco-regional control is slightly better when you give the radiation, pan-mucosal radiation.
Yes, sir.
Then the side effects may be more also. Side effects will be
Yes, that is why don't we give it to every patient? Why don't we give pan-mucosal radiation to every patient? As ma'am said, is because of the side effects. So these patients will have dysphagia, pain, and tube dependency, aspiration problem. So the more structures we radiate, more problems these patients are going to have in the post-operative period. More mucositis this patient is going to have, particularly after chemotherapy.
Yeah.
So you want to avoid and you want to cover the areas where there is a highest risk of harboring the primary tumor.
Yes.
Yes, ma'am.
If Akash, if FNAC or your cytopathology suggests adenocarcinoma, then what will be your next step? I think how will you proceed further?
Ma'am, if it comes out to be adenocarcinoma, then we will have to look for the sites like the salivary gland, the parotid, the submandibular gland, the sublingual gland, and look for primary metastasis there, or in the lungs if there is adenocarcinoma of the lung, that can give metastatic lymph node in the neck.
GIT areas? GIT.
Yes, ma'am.
Gastrointestinal, which areas? Carcinoma
Ma'am, pancreatic carcinoma.
Carcinoma stomach can also be there. Esophagus
Yes,
can be there. Pancreas can be there. And if below clavicle, then Dr. Vipin told you in the beginning, which are the 4 areas? When breast can produce adenocarcinoma.
Ma'am, breast cancer,
Areas,
lung
all
cancer.
those glandular areas, you have to remove.
Yes, ma'am.
Okay. Yes.
Dr. Raman, do we have more time or?
Sir, in next 15 minutes, we can combine. We have 15 minutes more.
15 minutes more we have. Okay.
15.
So can I ask a couple of more questions? Basically,
yes.
these are to cover the topic
please.
for all the
Yes,
postgraduate.
yes.
I think we are done with the case, but
Yes,
I wish
yes.
all the questions in all these cases should be known to all graduates who are spending their time online. So that is the whole purpose.
Yes.
Otherwise, we are done.
Yes.
Hello,
Akash?
Dr. Vipin. Dr.
Good evening,
Vipin.
sir.
Yes, sir. Good
Hello,
evening, sir.
Dr. Vipin. Good evening.
Good evening, Dr. Pasi sir. Good evening.
Good
I
evening,
was
sir.
late in,
Good evening,
yeah,
sir.
very good evening. I was late in joining, but I have joined for quite some time. I was not getting through my video and audio both somehow. But then I must appreciate Vipin for contributing so much in this case discussion. But I just wanted you have enumerated some of the complications of concurrent chemoradiation or chemoradiation post-operative. But I want a discussion on all the possible complications, including the fatal ones, after post-operative radiations.
Yeah.
Okay, Dr. Akash, can you tell us the complications in a patient in a patient who has undergone a neck dissection and then subsequent undergone chemoradiation? So, what are the likely complications that can happen in the neck?
Well, first of all, due to neck dissection, there can be bleeding, hematoma formation, then chyle leak, problems of the neck due to removal of the sternocleidomastoid,
No,
drooping of the shoulders
post-operative
due to
radiation after surgery.
Yeah. Surgery,
dysphagia.
there is no complication of surgery. We want to know the complications caused by radiations post-operative.
After surgery. Yeah.
Sir, coming to wound dehiscence can occur
Yes.
post surgery. Then dysphagia.
How will dysphagia happen? Because of the
Sir, because of
ulcers.
so mucosal strictures can occur in the esophagus. Aspiration can occur. Aspiration problems post radiotherapy. Xerostomia.
These are the general complications of radiotherapy anywhere. Radiation effects on the skin, on the mucosa. Okay, but what are the specific complications that can happen and sometimes can prove fatal?
Particularly the vascular problems.
Thrombosis can occur.
Suppose your flap was not adequate or it was thinned out, skin flap and the subcutaneous flaps were not adequate in strength, and you gave radiotherapy.
Sir, necrosis of the skin flap can occur.
No.
What next?
Sir, wound dehiscence
Anything
can
which
occur.
will happen to the major vessels.
Ma'am, thrombosis can occur of the major vessel.
Thrombosis.
Dr. Vipin, please elaborate on these.
Yeah.
The life-threatening problem that sir is hinting you is a fatal complication in the form of carotid blowout. So when there is inadequate cover over the vessels, and there is prone to infection, and especially if there is salivary leak also, if there is a fistula between the neck and the oral cavity, then there would be gradual erosion of the carotid wall, and then eventually it can lead to carotid blowout, which is a fatal condition in such cases. So you should always be aware of some sentinel bleed, because carotid wall is a very vascular structure. So there will always be a preceding some sort of sentinel bleed, which will let you know that it is about to blow up. And always try to cover the carotid in whichever surgery you are trying to do, and cover it well so that it is vascularized and doesn't blow out.
Vipin, I have seen one such case, and I cannot ever forget the sight of carotid blowout.
It's a life-changing event, sir.
Yes, true. Yeah.
So, Akash, do you know what is sentinel bleed, as Dr. Vipin has said? What is sentinel bleed? Did you?
Ma'am, it is the ma'am. Yes, ma'am. Just before the carotid is about to blow out, the vessels which are the small vessels which are present around the carotid, they start bleeding due to ulceration, and that is a warning sign for the patient and also for the doctor that the carotid is about to blow out. Ma'am, we
Yeah.
had a similar case 1 month back in the emergency where we lost the patient subsequently.
And Akash, I just want to tell this is external blowout. There can be even internal blowouts also. When the bleeding, when the tract forms inside, patient can have severe hemoptysis. Patient can have severe hematemesis also. So this problem can happen when there is an internal blowout also. That is even more difficult to
Yes, sir.
diagnose and
Yes, sir.
very difficult to treat. So what do you ligate in such a case? Nothing. You have nothing to ligate. You only depend on the radiology and then maybe coiling of the carotid artery. In external, you can at least tie the carotid, but internal, that option is also not available. So
Yes, sir.
whenever a patient has hematemesis or hemoptysis, always be careful that this could be an impending blowout.
Yes, sir.
Sir, ma'am, with your permission, should I
I
ask the
think,
resident to stop sharing the screen so that we can have a chat face to face? You can close your stop the share screen, Akash.
Yes, sir.
Okay. So we have 10 minutes more left for the discussion. So I request you to ask as many questions possible for the interest of residents.
Akash,
Yes, sir.
if your second provisional diagnosis is positive, suppose FNSC says that you have large B cell lymphoma, then how will you treat such kind of patient?
Sir, we will have to go for chemoradiation and along with that bone marrow transplantation.
Chemoradiation.
first you tell us how will you confirm the diagnosis, and then you will start the treatment or decide the treatment.
Sir, ma'am, we can go for core needle biopsy or excisional biopsy of the node for pathological confirmation of the diagnosis, and after that we'll have to go for chemotherapy and bone marrow transplantation.
Which chemotherapy you like to do? Which regime you like to give to the patient?
Sir, 5-fluorouracil.
What is the name of that regime? Have you heard the
Sir.
name of R-CHOP?
Yes, sir. Sir,
R-CHOP.
I'm not sure, sir.
R-CHOP regime for the lymphoma.
Yes,
What are the drugs included in this regime? Okay, R means rituximab. C means cyclophosphamide. H means doxorubicin. O means oncomine, that is vincristine. And P means prednisolone. But sometimes patient get some side effect due to vincristine, that is peripheral neuropathy. In such patient, you switch on to other regime, that is R mini CHOP regime. Then what is the R mini CHOP regime? Have you heard?
no, sir.
No. In some elderly patients, they are unable to tolerate this R-CHOP regime. In such condition, we give the same dose of the rituximab, but decreased dose of this CHOP. That is mini R-CHOP regime. Sometimes we give the prophylaxis to the patient in the form of rituximab. In such patient, they come with the bronchopneumonia. We should withdraw this rituximab also and wait and watch. We should do. It is vast subject practically. It will not complete into 10 to 20 minutes. Dr. Pasi sir, please.
Yes, I'm really very happy with Akash Gupta. Are you a third year PG?
At the
secondary
DNB
DNB.
second year, sir.
DNB second year. Good. So you have done fairly well. But I am missing Dr. Aditya Bhargav. Was he supposed to be there?
Dr.
had
Aditya
joined,
Bhargav
sir,
is
I don't
busy
know if he
somewhere
did.
today, I think so.
Yeah, there was
Okay.
some problem. I think he did not. He had joined initially.
Okay. The other thing I wanted to convey, Dr. Ranga, Dr. Raman, and Aditya Bhargav, everyone out of the senior faculty sitting here, Dr. Uma Garg, that our participation of the postgraduate student level is
Less.
not that good.
Yes.
Though it is not very bad also, but then keeping the number of medical colleges and number of PG students, including DNB students, the attendance in this group is
Should be more.
going a bit down. This is a matter of concern, and I will personally convey my feeling to all the academic heads and the other faculty members of all the Haryana medical colleges to be little more active. It is, I think, complacency on the part of our faculty members that we are not motivating our residents enough. And this is a real good activity, teaching activity. When Dr. Rupinder Ranga in full private practice can take that much pain and interest in academics, why not postgraduate students who are into academics only? Welcome, Dr. Preetham Arora. I am speaking something which is of concern to you also, that we have to ensure that this forum stays alive and it should progress and it should grow. We have Dr. Vipin today for his comments. It was really a very good contribution. So quality of the academic session must improve every time. But unfortunately, I am observing that the interest is going down and number of participants, especially the postgraduate students, is also decreasing.
Sir, I was
Dr.
already here, but for some reason I had to keep a video off.
It's all right, fine.
But I was definitely listening to everything.
No, I'm not. Dr. Ranga, you please respond to this thing.
Sir, I think some students are busy in the DNB exam. Due to that, less participation.
That is
No,
over. The
exam is
exam
over
got
today.
over yesterday.
Yesterday, sorry, yesterday. It is over yesterday.
This was over yesterday. And by the way, you have Dr. Raman Sharma sitting, though the result is yet an unofficial result, but he was also appearing and he got through. We can congratulate him.
Congratulations. Congratulations.
Congratulations.
Unofficial, of course.
You have made it official.
Congratulations, Dr. Raman.
Thank you very much, sir.
I think Dr. Ranga,
when we started this activity, there were more than 100 participants used to there. But now, gradually, the number of participants are decreasing. And mainly, I think it's a role of faculty only to motivate the students to join these activities. I have stopped sharing the videos on the live Haryana AY channel also, just for this reason, because the students, they think that the videos will be uploaded and we'll see again later on. So I think if this keeps on happening and if students are not interested, then even faculty they have more responsibilities. Even they will not come here in the interest of students.
The lecture series was designed for the
interest of
student and the DNB students.
Yes, because such kind of academic exposure was not
I
there
think we
in
should
Haryana.
go and again talk to academic heads, Dr. Ranga. One or two every time. We have to remind them.
Yeah, let us keep motivating them.
Yeah, the people who have postgraduate students, especially them.
We are putting the information of this live lecture series 2 or 3 times in a week. In the morning, just to remind, we put this information on the WhatsApp group of the AOI
I think
Haryana and social Haryana also.
फोन
Doctor,
करके भी एक व्यक्ति को बोलना
Dr. Ranga,
पड़ेगा.
a telephonic call will help you more.
Okay, sir, we will try to. Dr. Raman and we.
Yes.
Yes.
Please do
So,
that.
In the last, I would like to welcome the comments from our external, Dr. Vipin Arora, sir. Please say, sir, a few words at the end about the performance of the candidate and the lecture today, the program. Please, sir.
Yeah, he did well that way. He answered most of the questions. So congratulations to you, Dr. Akash. And as Dr. Pasi said, that there must be more interest in the students than than the faculty. I think it's the faculty is more interested. But anyhow, he did well. And one last comment I wish to make is that what is the overall survival of a metastatic neck disease with unknown primary? What is the 5-year survival rate? You should remember this. What actually happens to eventually what happens to these patients? You have treated them, they have undergone radiation depending on the merits of the case. They have received chemo if they require. So eventually what will happen is that 80% of these patients will never manifest any primary in the subsequent 5 years. And the overall survival will be around 50 to 77% of these patients will survive in the next 5 years. And they will eventually die of the recurrences. And the recurrences, they will not die of the primary, but they'll die of the recurrence at the same site. And that is how it all ends.
Must be depending on the stage also, no, of end stage.
Obviously.
Whether it...
Yeah. And the best outcome is for squamous cell.
Yeah.
The highest overall survival is for squamous cell, and the worst is for adenocarcinoma and the neurogenic tumors, neuroendocrine tumors, which we usually see in the supraglottic part. So this is how it goes. And thank you, Dr. Raman, and thank you, Dr. Rupinder, sir, and Dr. Pasi, sir, for having me here. That's all I have to say.
Thank you very much, sir, for sparing your time. So, Dr. Rupinder Ranga, sir, please say a few words and you can conclude the session, sir.
Have we answered all the... is there any question in the chat box to be answered?
Yes, ma'am, there is one question from Divash S. Is there any role of tumor markers in carcinoma of unknown primary?
I think Dr. Akash can answer that. Dr. Akash, I think we discussed that, no? No.
Ma'am, I could not hear, ma'am.
The role of tumor markers in carcinoma of unknown primary.
Sir, we can prognosticate the role of tumor markers, and it will
There
only...
is a role you want to say. There's a role.
Sir, ma'am, it can support the diagnosis in this case. The diagnosis of mainly whatever the histopathological diagnosis is, you can correlate it with the tumor markers. And ma'am, in some carcinomas like buccal carcinoma, the role of MU, that is MUC4, further studies are going on, that is mucin 4, which can prognosticate the disease if it is more. That is mucin 4 is, if it is more, then it has a better prognosis, and if it is the mucin 4 is less, it has a worse prognosis.
It's all under study. Still, we cannot say clearly. So they can act as good diagnostic as well as prognostic markers in CUP also, carcinoma of unknown. Right?
Yes,
thank you, ma'am. Now, Rupinder Ranga, sir, please.
Good evening, all the dignitaries. I think it was the well attended Zoom meeting by AOI Haryana. I am thankful to Dr. Akash Gupta, DNB second year student at BPS Medical College, Kanpur. And Dr. Akash, I think, answer all the queries. It's the hard work done by you. I congratulate you. And this show that the standard of BPS Medical College, Kanpur education standard. It is very high, I think so. I'm thankful to our experts Dr. Aditya Bhargav, Dr. Uma Garg, and Dr. Vipin Arora. They all one interact a lot and make it very fruitful to everyone who are attending this Zoom meeting. And I am also thankful to course coordinator, Dr. Raman Sharma, and Dr. J.C. Pasi, that's a instrumental to AOI Haryana. I am thankful to all the members who log in this Zoom meeting today. Thank you, everyone. Thank you very much.
Thank you very much,
Thank
sir.
you, sir.
Good night, sir.
Thank you.
Thank you.
Thanks, sir.